speaker and our case presenter today. Our didactic presenter, I think many of you are familiar with from prior clinics, and we want to welcome Dr. Jeremy Carpenter, who is board certified in addiction medicine and in general psychiatry. He got his undergraduate degree from Ohio State University and spent time in China studying molecular biology, although I doubt he's probably going to talk to us about that today. He went to University of Cincinnati to medical school and George Washington University for general psychiatry, completing a fellowship at Nationwide Children's Hospital in Columbus. He is the lead medical director for Brightview Health's newest location in Fairfield, Ohio. Our case presenters today are from Valley Community Health Center in Grand Forks, and there are two of them. First is Robin Landwehr, who's the integrated care manager for Valley Community, and she provides behavioral health consultation as well as staff and intern supervision at their FQA location. She's a licensed professional clinical counselor in North Dakota, a licensed professional clinical counselor in Minnesota, and a licensed mental health counselor in Florida. That's probably an interesting story too. Robin has a Master's of Science degree in mental health counseling and a doctorate of behavioral health degree from Arizona State University. The other case presenter is Christine Harsel, and she has a BS in nursing from Montana State University, and a master's in nursing from Syracuse University, and a DNP from University of Minnesota. She's an adult nurse practitioner and medical director for Valley Community Health Center with locations in Grand Forks and Larimore. She's held various teaching positions at the UND College of Nursing and Professional Disciplines and is currently working at UND with the Mountain Plains ATTC grant. So with that, I'm going to turn it over to Dr. Carpenter, except I do want to say one thing about that transition. We've previously had an introduction lecture on motivational interviewing in which Dr. Carpenter talked about how this is, it is both simple and extremely complex to execute. And we promised you that we would be back later this year with some tangible kind of entry-level skills that you could think about would potentially be really relevant in the primary care setting when you're meeting with patients or in any clinical care setting where you're meeting with patients who may not be prepared to talk about what you want to talk about. So Dr. Carpenter has kindly agreed to help us today to kind of talk through some of those basic elementary skills to help you get a little bit more comfortable with that. And following his presentation, I think that we're going to have a case presentation that probably illustrates the need to have agenda setting. A good one. So with that, I'm going to turn it over to
Great. I'm hearing a wicked echo. Is everybody It's like a remix of this. This is very hip.
I think I've muted where the echo is coming from, so.
Wiki. Sorry. That was actually pretty amazing. So let us get started. All right. I forgot to share my screen. I apologize. One moment. Desktop. Share. Can everybody see that?
Yes.
Awesome. All right. So I am going to start our slideshow here and not narrate absolutely everything. So motivational interviewing, setting the agenda. So that's good to know. So I haven't been a part of some of the other ECHO lectures since the motivational interviewing one. So that's helpful to know kind of where to put this in context. And so regarding setting the agenda, it sounds very simple, and in a way it is. What I was going to do today, they actually have a specific way of doing this within motivational interviewing, and it's called agenda mapping. Now, this, and actually I will send out the article that describes it. So the thing about it though is that when we go through this, this general skill is maybe geared towards more individuals seeking kind of personal change. I mean, we're going to go through some tangible ideas of how to do this, like for substance abuse or in a primary care office, but just bear with it, because the first couple steps are, what do you want to do? What are your life's hopes and dreams? And then you create this really pretty map and you draw lines, and it's puppy dogs for everybody, but nobody has time for that. But the actual skill is very helpful. We'll go through some cases, and we'll have some of our own cases. So in general, when we're going through this specific skill, we want to describe the general process of agenda mapping and how it's characterized typically in motivational interviewing. Break it down into 3 components: what to do if you're having a missing agenda or incomplete agenda, and then just to talk a little bit about at least 2, but hopefully we'll go through some more ways that this can be useful. And again, we will make it more tangible here. So the first step is that motivational interviewing is actually just kind of historically, it is newer-ish. And in fact, just within like the last 5 to 10 years, or even just the last 5 years or so, they kind of make modifications or tweaks. Some of these are authorized, some of these are not. But one of the things that people thought was, we have the ORs, and we'll go through that mnemonic in just a second, but one of the skills that they thought was really important to be intentional about was agenda mapping. So we're going to review this technique, which is typically not always a formalized part of practice. I don't think we talked about it the last time we did the presentation. And in general, it's an agreement on the focus of the conversation. As a background, so motivational interviewing, it is not a technique. It's not a form of therapy. It's a set of principles, which is actually really good because you can come across almost like really creepy if you try and like stop and think exactly what you're supposed to say, and you're like, I'm supposed to reflect and you just kind of look weird. So ideally though, it's a set of principles, meaning that you kind of have a goal in mind. And I really think all of us are capable of it, but with just a little bit of intentionality, you get a lot of bang for your buck. So again, stick with the core principles. It's not another technique. And ideally, and what this article says is that if a provider follows the principles, an effective relationship will be built, and you can move on to change from there. So big in MI is the ORs. They were desperate for an acronym, ORs. Wow. Okay, so open-ended questions, affirming statements, reflection, and summary. I really wanted to come up with an actual visual aid that could help explain this, but whenever I think about motivational interviewing, I kind of have this idea in my head. A provider and a patient, facing each other. And, one of the things I've learned to do in psychiatry is, we talk a lot about thought content. And what I've kind of taken from that is that if I could take all of your thoughts over the last 24 hours, and I could just kind of view them, what would they be like? Would they be super negative? Would they be totally bizarre and out there? And that's kind of what you want to do. At a really basic level, one way of doing motivational interviewing is if you are trying to move someone and move them towards a state of change, you basically let them speak for a little bit, and you look at their kind of verbal content as all these like little things that kind of come out. Anything that you see that's on the table that's like, I can work with that, you reflect that back. Anything that was maybe particularly not helpful, like drugs are not bad, they're good, you kind of put to the side, and you kind of think about other ways of reflecting that back, such as that other component of motivational interviewing, developing discrepancy. I hear you say, and I have this whole table analogy, and nobody can see it, but it's, for example, saying, I hear you saying that drugs are the only way for you to get through this period. I also hear you saying that you can't see your kids, and that's something you really want to do. So that kind of discrepancy is the kind of thing that once kind of brought up, hopefully doesn't lead somebody to storming out of your office. Typically, it leads into a conversation and kind of the next step on the route of talking and change. And again, it's about getting them to talk openly, being active and empathetic. we just had a presentation on it here. There is a lot in psychiatry because people are always trying to take out, well, what is it within therapy that is helpful and helps these patients? And, you know, so many times they'll compare therapies, and some types of therapies are more effective, like in a certain diagnosis, but many times, if you compare evidence-based methods, they're all kind of equivalent, and then they take out traits such as, you know, the relationship, the altruism, the empathy. So a lot of healing comes from just forming this relationship. Also, this was interesting, I had not heard before, but although levels of attachment and a feeling of being on the same page as your, you know, therapist or your provider was important and associated with change, another really important factor was also the provider's feeling of confidence about the method. Meaning that you can have the best relationship in the world, and if you don't feel confident about what you're doing, it doesn't come off kind of well. That said, I mean, that's just, you still try and move forward. You do not have to master this in order to move forward with it. I'm gonna peek at something real quick. Good, okay. So this is another, so in reviewing the 4 stages, so the first part is engaging. So you're just really building a relationship, building trust, focusing, the strategic focus. So this is when you've got all that thought content out, and the focusing part is the agenda setting, or in this case, agenda mapping. Once you pick the topics you're gonna go for, you delve a little bit deeper into that, and then you explore them together in a way that move somebody towards a stated goal, or if you're working with somebody together on their diabetes or substance use, that hopefully moves them in a way where they can eventually make a planning statement, and then you follow through with the plan to see if they move forward with it. And then, so why doing agenda setting? I know there's a really professional way to actually cite journal articles, and I'm so sorry I didn't have time to do it. But this was an article that actually came about from my addiction recertification, and I thought it was really interesting. So it was an article that was called "Elements That Define Recovery: The Experiential Perspective." And basically, they asked a bunch of people to rate different ideas or concepts of what is essentially a part of recovery and what kind of is and what kind of isn't. The interesting thing that although there were some really common agreements on, and these were individuals that were successfully, in recovery. I apologize. No, they had various degrees of recovery, but I think that they had at least 30 days sobriety is what it was. But basically, the interesting part is that although sobriety from substances was important in defining recovery, there were actually a whole bunch of other factors that outranked just purely being off of substances, which is interesting because, even from a diagnostic perspective, the best way I can tell somebody how their substance use disorder is for the most part, how their drug screens are looking. But to other people, there were 6 other ones. So the idea of being able to be really honest with yourself, handling negative feelings without using drugs or alcohol, being able to enjoy life without drugs or without drinking or using drugs like I used to. So the interesting thing is that although in some of these, sobriety is implied explicitly or implicitly, it's more than just, if our agenda is getting people off of drugs, it can still be pretty miserable. And it's interesting, so there's an analogy I use. So people develop relationships to people. They also develop relationships to behaviors, to things. If you had a really bad relationship with a person, volatile, codependent, domestically violent, it would be kind of like a no-duh thing to, separate yourself from that relationship. So, but when we have people separate themselves from relationships, we don't have them abstain from relationships completely. And I know this maybe not be a perfect analogy for substances, but people do relate to substances, and that kind of relationship is similar. And if we just focus on the abstinence, but not, on the other things that will help them stay balanced and pursue that, then we can fall short. And we don't have to guess, we can ask them through this process. They were so big on this in the article, and I thought it was kind of dumb, but I thought I'd put it in. So they're all into this is a meta conversation, meaning you're having a conversation about the conversation, which sounds really cool. And it is important though, because if you don't stop, and there's some examples that they actually give later of saying, you know what, let's take stock. What do we want to make sure to accomplish today? If we don't make it intentional, it really doesn't happen. And again, it's about focusing, establishing the focus. And I think I'm going to touch base on this again later, but it is an amazing thing that there's a number of patients who really might not have the skill set to just kind of stop, list things, and talk about them. As simple as it may sound, just this process alone is enough to be like, oh my gosh, I have to stop doing this. Because there are a number of individuals who, due to a lack of skills or chaotic environment, they don't do this. I don't do this all the time. So again, the components. It's the form of a series of questions, and the first thing is, again, agreeing to this meta conversation. Some examples are, is it okay if we spend a few minutes exploring what you want to get from meeting today? Which you kind of never would open up a primary care provider. So that's opening up for a lot of like, well, there's this and this and this. So there are some ways to make it more concrete. But in general, you do want to know, let's stop now. What are some things we've talked about a little bit, but what do you want to make sure that we accomplish during this session? The second element is to help identify the objectives of the patient, meaning you identify something. So once identified, the patient's doctor can help prioritize these and settle on a specific focus. And then you refine and clarify. We'll talk about what to do if we think things are, like if they say, oh, I don't have anything to talk about, or we think that there's something glaring that we should talk about. We'll do that in a second. But what is important, let's see. Oh, sorry, lost my train of thought. But what we do want to do is, in addition to identifying these, it's helpful to know kind of like what their expectation is. So, many of us have sat down with a patient who says, well, one of the things I want to accomplish is talking about anxiety. And you think, oh my gosh, I just read this review article. Like, my specialty is in anxiety training. This is what we're going to do. Aren't you excited? And really, they had this one thing in mind that worked for their nephew's cousin's dog, and they really wanted to be on that certain thing. And they're not going to tell you that by the time that you've given them this wonderful speech about why maybe Shalene is better. And so sometimes the patient may leave, they might not take it. For a variety of things can happen. So in addition to knowing what the person wants to talk about, especially if they have a history of treatment with it, like somebody's seeing you for diabetes for the first time. All right. So we absolutely are going to talk about your diabetes today, but are there things that I should know about what's worked for you? Or is there anything in particular you want to make sure we talk about, that like certain treatment options or concerns that you may have? That too can really help things along. So it is not uncommon for people to have a number of goals, and it is the task of the provider to help them either take a bunch of those little goals and put it into a larger one with little goals, or kind of just say pause. And typically what I will do is at the beginning of a follow-up visit is, and one of the things that we'll talk about too is that it can be really helpful, especially for really complicated patients, to give them a form to fill out that basically kind of asks everything you would in the first 10 minutes, and it gets it there on paper. So it saves time, and then you can say, is there anything else that you want to talk about that's not on here? But with that though, if somebody is still very disorganized, you let them talk for about 1 to 2 minutes, and you try and get some ideas of things. But if you can't, you write down the first 3 and you say, well, I want to focus on these, and then I have some additional things to talk with you about. Or if you can, if they're talking about like they want help with their anxiety, they're having, cold, hot, they're having cold chills, and they're having feelings of heat waves, they're tremulous, well, let's get you not withdrawing from opiates. I know that's kind of overly simplified, but again, the goal is to try and help either by limiting the number or saying, it sounds like what we need to do is move forward with addiction treatment or a nutritional referral. Skip 2. Again, stay kind of superficial, but in a meaningful and empathetic way. That's kind of it's possible. Again, you will be able to develop things in a much more concrete and specific way, but it's important really almost just to get thought content going. All of us have kind of experienced that, or you know what, I know I'm leaving right now, but I forgot to say this. That's why it's almost great. It's the most wonderful thing to be in attending, I have to say, because by the time a medical assistant has checked them in, a nurse has seen them, the medical student has seen them, the resident has seen them, you walk in and then you ask, what is it that you came in for today? And it's like, all of a sudden there's some unaccessed, history that you were able to pull out and everybody thinks you're amazing. There is this benefit of almost kind of repeat, not in an annoying, obnoxious way, but kind of repeatedly asking somebody if there's anything else. One, they kind of take stock in, is there anything else? Or two, after enough prompts, that thing like erectile dysfunction is finally not embarrassing enough to keep me from talking about it. How to begin. So always, if you're going to do this process of change, it's important to do it at the beginning. Again, like the example of prescribing a medicine for anxiety, you don't have to prescribe that, off-labeled, not great choice, but the idea of letting the person talk about it and say, you know what, we're not going to do that because that actually kills people or whatever. It's not indicated. It's not the first line treatment. But we'll keep that in mind. However, there's this. So it's important to do it at the front end. And again, in addition to helping kind of set a clear goal, you kind of are making sure that there's not any kind of expectations that you're not meeting. And again, what should we focus on today? What would you like to address? And then that repeat. Is there anything else we haven't added to the list? So what do you do if somebody comes in and they have no agenda? I am sorry that 2 of these are bolded. That's a really big pet peeve of me. I'm very sorry. With a clear agenda, you're able to move forward, and that's super important to do. So they have these kind of again, these are more therapeutic, so sometimes they might say, on a scale of 0 to 10, how is your life? It's a 2. Well, what would it take to be like a 3 or 4? Or how would you like your future to be different? Well, do you have any concerns about your health or any problems? And, one that's kind of helpful is, have your friends or family members suggested that you come here for any particular reason? Your probation officer or whatever. But the idea then is that even if somebody continues to say no, no, no for all of these, you still have other options. We'll talk about those in a second. But again, it's always important to at least push to try and get that agenda. So this is kind of what I was referring to. So this helps not just for no agenda, but an incomplete agenda. So somebody comes in, and one time I remember seeing this cartoon, and this guy walks into the doctor's office and he has an arrow through his head, and the doctor's like, oh my gosh, what can I do? And the guy says something about he has a splinter. I mean, it's meant to be I know you're worried about the splinter, but this very obvious glaring thing is going on. So an incomplete agenda could be that. It could be something that is going on, but they don't bring up, or something that just after questioning them a little bit more, they'll actually kind of come out with. So ways that they suggest doing that is, I hear you want to talk about anxiety, but why are we not talking about, the fact of all the stressors you have going on, the dangerous relationship that you're in, or if they don't bring it up at all, another thing to do is, I want to talk with you about, your anxiety and ADHD, but I've wondered, how have you been doing regarding your, addiction to opiates, or, what's going on with that? It's helpful. Some of the good things about these questions are that it's more of it's not like shutting somebody down and taking the steering wheel, but it's asking for permission. Is it okay if we shift direction? I will make sure that we talk about those things, but I did want to talk with you about this. The kind of squarey looking thing at the bottom. So this was something that a attending explained to me, or used as kind of a tool during my general residency. So he said, whenever you're seeing a patient, think of quadrants. And in those 4 quadrants, there's history, physical exam, labs and studies, and collateral information. And this was in the setting of psychiatric treatment. He was saying that, if you're going to move forward with diagnosis and treatment, make sure that you have at least 2 of the 4 before moving forward. So basically, if somebody says history, subjective wise, I am super bipolar, racing thoughts, however, the physical exam is anything but that, it should be a reason to pause. Especially if their labs or their toxicology studies suggest, either some sort of metabolic imbalance or, the fact that they have substances on board. So this quadrant thing can still come into play because as we're getting somebody's subjective thing physically, I remember there was a super routine follow-up this week of a gentleman who's been, sober, doing great for a year. I mean, he's always super happy and just full of life. And he came in today. His urine toxicologies were as good as ever. He's attending things, but I actually just stopped him and said, no, I hear all this stuff is going well, but I'm noticing you don't look like yourself. What's going on? And then he went to account how there's a bunch of personal issues going on. So although this seems like, is that really motivational interviewing? Again, like it's a set of principles, and it's important to, especially when you are setting this agenda or mapping the agenda, to again, ask kind of repeatedly and then take into stock other things. So I put on here, so our prescription monitoring database is called ORS, or the toxicology studies. Very frequently people will come in, or not very frequently, people will come in and say, like, I'm doing super good with my recovery, I'm taking my medications, and on these confirmatories, there's like 2 in the last 2 months that have had like the smallest amount of fentanyl in it. And what I typically do with that is that I am so glad. I see you are attending. I can see that you're taking your medication. I'm so glad you're feeling well, and this is awesome. At the same time, there's something we need to talk about. So twice in the last 2 months, fentanyl has been positive. Well, could that be a false positive? Well, no, this absolutely would identify it. Is it something I could get by touching? No. And the way that conversation moves sometimes, I know this is a little bit different than agenda setting, but you're making sure to have a complete discussion and you're not like leaving things out. It can be super easy to have like a complicated patient and you get done and you realize, I didn't review those labs. They're going to come back in 2 weeks. It's helpful basically to try and be as complete and bring up the topics. So this is why they call it mapping or agenda mapping. So the idea is that you have all these circles on the paper and you kind of fill them in. And then you kind of show them that map of things and say, these are all the places that we could go today. Which destinations are going to be the most important. So they kind of try and make it pretty visual. And again, like, even if nothing else happens after the agenda mapping, you are helping somebody go through the process of generating alternative options, even just identifying what's going on. You're actually having them agreeing to focus on something and giving them an idea of what clear thinking can be. And as simple as it sounds, that can be huge for some people. So also, this is, I think these are going to be 2 examples of how the process can help you as well. So even if you don't get that great agenda, there are times that people want to move forward with, maybe a certain type of treatment, or my list of analogies are kind of running really bad today, so just please go with me. But so somebody that comes in and they say that they want recovery, and okay, so what are the things that are really problematic for you? You go through all the skills, you try to agenda map. They're like, I just want to stop, and you realize that nothing is being generated. So at that point, you say, so why are you here? Sometimes not having a clear agenda is an example of somebody's not ready to move forward. And as opposed to pushing them forward, just kind of exploring options of you don't have to be here. This doesn't have to look like for everybody else. Just what would you like to have happen? Or who's encouraging you to do this that you're having a problem with? And so again, if somebody is in that more pre-contemplative state, like they actually don't mind the fact that they do a whole lot of marijuana, but their probation officer says they have to stop. Then your job is less about moving them through those motivational interviewing steps and creating discordance, and you just start raising awareness, basically maybe pointing out things in their life, ways that marijuana has led to problems. let's see. And then again, the more clearly defined and the more personal goal, the more likely the provider will be able to move towards change. I didn't know how this was going to work out. So this is an example of a form that I give to a lot of my follow-ups. And it doesn't take them too long. And I've gone through like a bajillion different renditions of it. But by the end of it, they fill it out. I get a general sense of how they're doing. Do they have any questions? What substances have they used? Making them say yes or no. Because it's kind of a pain. Like if you're seeing somebody for addiction, to ask them about every single one. Checking in about addiction symptoms, significant mental health symptoms, a general review of systems. So by the time I get the chart, I look at it real quick, I kind of know where I want to go, but then again, the first thing I ask them is that, thank you so much for filling this out. So anything that is not on this that you want to make sure to talk about? No? Okay. Do you have any concerns about treatment? Anything not on here? No? Okay. And 99 times out of 10, not possible, but 9 times out of 10, it just moves forward, and it's a chance to kind of have everything out and be able to address. And again, especially the things that they bring forward, it's important to ask not only what they want to talk about, but is there anything in particular about it? Like, are there certain treatment options? Is there certain aspects about it that you want to talk about? Oh no, I thought I had something else. Well, I am so sorry. How are we doing for time?
I think we're doing fine for time. You got more to say, or do you want to take some questions?
Yeah, let me just take a look real quick. So not just topics, desired outcomes. Yeah, let's just start off with questions first of all. Are there any questions at all? And if not, we can just touch base on examples.
This is Dave Schmitz, one of the Project Echo hubs, and I'd like to ask a question.
Yeah.
You talked about having kind of confidence with the process, and it seems to me this is something that, I don't know if it was, I'm not a psychiatrist, but as a primary care provider, practice really helps with regard to learning a new skill set. And so do you think role play would be helpful for this? And have you learned in that? I probably would be, maybe better at being the patient, but I could see where maybe in a residency program or something, we could almost try to role play some of these skills.
That's a great question. And in fact, that is actually how we, when we learned this, it was like, pretty sure it was like, 1 hour for 2 weeks. We paired up with somebody and then we did nothing but, just try and do this. Now, in that case, they were being way more severe about, did you do the O, did you do the A, did you do the R, versus like the idea of just, practicing this, or even like thinking. So yes, so I think within a training program, practicing it can be really helpful. When I had a practice and I was trying to teach staff about this in general, one of the things that we did, and it was actually kind of helpful. So we taught them each these are the 4 typical things that you would respond with. And so we did this almost round robin where we started at one end of the table and I was the patient, I said something, and then they had to pick an OARS to respond back to what I just said. And then I would say something and the next person would pick an OARS. And it's not perfect, but it actually was interesting to see other people do it. But yes, I think it lends itself to practice very well.
And maybe just one follow-up question, and then I'll leave it to the rest of the group. It seems like there's, I'm going to call it a risk of generating significant cognitive dissonance here for the patient. So if you have someone who perhaps is in some state of denial or intoxication or whatnot, and says, I really feel like I need this substance to get by in this period of my life, and then you confront them with, but I'm hearing you also say that you really wish you could see your children again. Do you sometimes run a risk of pushing somebody to a place that you've actually caused harm? I don't know.
No, that is a great, when you were speaking about that, there was this one, it was, I don't know if it was a Stephen King book, and it was but it was about 4 friends. Basically, they all get some sort of like weird superpower. This one that can read people's minds becomes a psychiatrist, and just because he's super upset one day, like, basically totally said what was on a patient's mind, and it was actually super disturbing. The patient ended up running out, and they were really harmed by it. So I do think about that because, these are tools, and this tool is actually helping you to kind of in a helpful way be confrontational. But for the most part, and we can talk about some other examples in a sec, but just the idea of pointing out glaring differences, the idea of being that kind of fumbling Columbo. And I almost like actually like on my desk. So as opposed to like looking at somebody straight on and saying trying to confront them, I'll say, help me out with this, okay? Because I see that you want help with this, but this is going on. Have you thought about that, or how have you managed that so far? And that alone is a way to kind of broach somewhat, a series of maybe kind of dissonant subjects. It can move towards, there's people who, like for example, somebody in aftercare that has been sober for a year, and again, they come up positive for fentanyl one time. It's the first time in like 6 months. And they swear to you that they haven't done it, and that that's their urine, and the technology identified it. It's a confirmatory test. You kind of weigh out your options. What I like doing is that, especially if it's the first one, I say, I do see that, and just so you know, so somehow this was identified in the urine, but I hear you saying that you're not. I look, you're engaging, you're doing well. I just say we move forward. I'd say you're still super successful, and let's just move forward and monitor. Now, like, there are patients too who I will say, Miss So-and-so, this is the 3rd appointment where you have 3 types of benzodiazepines in your urine. And for the 3rd time, she says, absolutely, I don't know how that's happening. So the way you kind of approach that then is that, oh, okay, I choose to believe you. I'm not going out and seeking this out. However, somehow you are in an environment where sedatives can make it into your body, and it's not good. So even if we don't know how it's happening, it is. So let's move forward with it. So there are kind of ways of making it more about the problem, and it is okay at times. Like if you're worried about saving face, what you do is you just say, you know what, I trust you. One of the things I like to do is, if you constantly walk into every session of, I'm going to believe that this person is positive, they're here because they want to get better, and they just are seeking more goodness in their life. And I know that sounds like a weird affirmation, but if you start off with that, you treat people with respect, you have positivity, and then these other things that kind of show up are just exceptions to that rule. And you basically then say, like, I know you are fighting for your kids. You have completed all of your assessments. You're doing fantastic. I want you to know that. Let's talk about this, though. So having that perspective and thinking of these things as more as exceptions can be helpful.
Yeah, I like that idea of presenting the dissonance without making it an interpersonal confrontation, and pairing that with some positive affirmation statements.
No, absolutely. And that is probably, and it's more than just a technique. There is, we have to be black and white because we have to do something, document something, but it's important and it's therapeutic to still let them know, like, you need to persevere. You're doing great, but we really need to work on this. So I think that was a great question. Anybody else?
Yeah, I had a quick question. This is Kurt Snyder. My question would be, how much do you pay attention to the stages of change in your thinking about your interaction with people, and does it make your intentionality a little differently with your motivational interviewing, and kind of even around the expectations of the patient, in terms of they're doing certain behaviors, well, okay, that's expected because of kind of the stage of change. How important is the stages of change in motivational interviewing?
So so that is a great question. And to be honest, I am always, when I go back and look at it, so I don't always think about them like explicitly, meaning though that there are times like in preparing for this, And, you know, I'm reminded of like, what do you do at different levels of change? I'm reminded, you know, about them and what they mean. And it's, you know, brings a bit of like, you know, maybe I should try that with this patient next time. But in general, you do not have to be absolutely minded with those stages of change in doing motivational interviewing. And the reason is this. Really, again, because it's not a specific technique, you can gear it to any different stage. Meaning that like if they're pre-contemplative, you're just listening, bringing things to their awareness, and seeing if they respond to that dissonance. If are beyond that, then you give them, you know, all the things that sound like a intentional action step, and then you help them with that. So, I mean, in my mind, it's kind of like if this is your baseline, meaning that you kind of, it's like a dance. You start off letting them kind of say what they want to work on first. You do these kind of skills, you take into account, and you just, you know, again, the exceptions are just that, exceptions. They are positive, they're moving towards treatment. So if you do all these things, like, but it's not working, then that's when I kind of pause and say, well, what's going on? Because again, in my mind, I'm thinking when I'm meeting with somebody, like I have a set of skills which works 80 to 85% of the time, and it's basically kind of made up of this. So when it's not working, I think not so much stage of change, but like what else is in the room that is making this like a really bizarre conversation? So, and you said, you know, ultimately, it's been really weird. The longer I've been in addiction, but it's to your other question, you know, more severe cases, the things that you do become, you know, although you stick with evidence-based practices first, and then it becomes these kind of calculated risks to try and help people. And also, you know, this certain amount of like, how much grace do you extend? You know, and it's come to the point where like, so, you know, with that, depending on their stage of change, and nobody is ever just in one. I think that's like a horrible fallacy, and people like go back and forth between like in one interaction. But, you know, like right now in practice, there is a gentleman who has been horribly addicted to heroin and meth. And for the last 6 months, he has been heroin free and doing less meth, but it's still present on like all of his toxins. And that's when you just stop and think like, one of the risks that can happen when you have a set of skills like this is that you always think you need to move forward. And sometimes it is just about preserving what you have had. For example, that gentleman, we tried 2 different things to try and change his relationship with methamphetamine. You know, they didn't work. So the intentional decision is to monitor it and continue to weigh the risks because there was this benefit. So as long as you're intentionally identifying things, again, the patient that 1 year sober and now they're positive for fentanyl, don't not address it, but, you know, address it and then put it in context with everything. Does that answer your kind of question?
You bet. Thank you.
Oh, thank you.
So do we have any last questions?
Well, thank you guys very much.
Yeah. So I think that Dr. Carpenter perhaps unintentionally set the stage for the case presentation because there's I think a central question in this case about harm reduction and readiness for change. So I'd like to turn this over to the Valley Community team now, if you're ready to present your case.
We are. Can you hear me?
I can.
Okay, great. This is Chris. Thanks for letting us present today. So we recently saw a 54-year-old female. She presented to our clinic basically to establish care and requesting to start on medication-assisted treatment. She has a pretty significant history of coronary artery disease. She's actually had a CABG, carotid stenosis, type 2 diabetes, hypertension, hyperlipidemia, migraines, and then of course the chronic back pain and anxiety. Her urine drug screen in the office was also positive for buprenorphine and THC. She had her lab showed some declining kidney function, and I won't read you off the list of meds, but she's on an extensive list of medicines, and the one that caught her eye the most was that she takes some clonazepam, 1 milligram 3 times a day. She's been using opioid pain medication, oxycodone. She was prescribed 20 milligrams 3 times a day, although she was blowing through that much quicker when we started talking to her more. It was the chronic back pain issues that led to increased dosages, and she really started misusing after her son died of a heroin overdose, which is ironic, but that's when she noted that she really just started not caring, and that was in 2012. She reported to the team, again, when patients come in to Valley, they see a provider, a nurse, and a behavioral health specialist. So this is a piece together history between all the interviews. We get the same sort of thing of everybody gets a little bit more of the story as you talk to them. She believes that she started taking opioids. She believes at some point she just started taking the opioids to get high. She often forgets how much she took, has periods of blacking out. And that really has gotten her scared recently. She's not officially tried any MAT or Suboxone before, but she has bought some Suboxone on the street. She takes the clonazepam, like I said, 3 times a day, but is very resistant to stopping. She smokes marijuana regularly, doesn't really want to stop that. She's been seen and left by multiple providers in our area since relocating here in the last year, and it seems like most of that is surrounded by the conversations about the risk of the increasing dosage and the risk of the benzo plus opioids are what sort of lead her to get upset with the provider and leave. So our primary concern is, does she have an opioid use disorder? We believe she did, but also has some other perhaps addictions going on as well. Would she be an appropriate candidate for office-based treatment given her concurrent drug use, the current high doses of benzodiazepine, and her other chronic comorbidities? She's pretty resistant to change from our perspective at this point. She did not want to wean off of any of the other things, the benzos and the THC. Triggers and stressors for her were her pain, anxiety, thoughts about her son, the withdrawal symptoms. And then some things that we started with. So we have not yet started this patient on any MAT. We wanted to see what our cardiologist thought about it. We wanted to consult with our favorite psychiatrist. We wanted some discussions started about weaning benzodiazepines, discussions about decreasing her marijuana use, her to engage in some therapy to work on other strategies rather than going to the benzos to eliminate, reduce her anxiety, and then we would discuss starting the MAT. And so our real dilemma with the team was, so she's got this pain, she's going to want pain meds. What's the dilemma of reducing harm? Is the MAT safer at this point versus making her sort of jump through these hoops before we start the MAT? And we really haven't come to a solid conclusion about that one yet. So we'd love some thoughts and opinions.
And what did Lisa end up doing yesterday, Chris?
Oh yeah, so she, thank you, Dr. McLean. So I originally saw this patient a week ago and then promptly went on vacation and had her follow up with another provider. And so she saw Lisa, who's our other nurse practitioner, yesterday. And I don't know, Lisa, you want to give a quick update what she had done?
So Chris gave her some hydrocodone to get through the weekend, and she took 100 milligrams on Monday instead of 30. And then she was going to start her buprenorphine. And then she had taken more clonazepam than she was supposed to.
Can I interrupt you? Let me get you a little closer to the microphone. I think you're kind of cutting out. We're having trouble hearing you.
Sure. So she took all of her hydrocodone in one day instead of over, I think,
I had given her a short prescription to get her through the weekend because we weren't starting MAT, with a discussion that she'd need to start getting weaned and be in withdrawal. But yeah, when she came back, she had basically taken it all in one day and was not really weaning the benzos yet.
Yeah. So we talked about it, and as of yesterday, she was very willing to give up her benzos and start buprenorphine. So Kristen, our nurse, had her turn in a bunch of her clonazepam and just gave her enough to take one twice a day. And then we talked about her coming back today to be started on it, but we have not found out yet if she's in withdrawal or what her story is. She's supposed to come soon.
So, and if I can just add in, so this was a great case, and actually a really nice example of team communicating together, but yet still having some differences of opinion as we work through this. There's the harm reduction issue. For better or worse, I've been doing some outside work where I've seen some bad situations with people with real significant cardiopulmonary problems, medications, even inpatient, and things going south. And so part of it was, trying to make sure we didn't contribute to the harm, or at least we weighed that with, the outpatient treatment and all of what we know might be happening out on the street. So part of the conversation was, does she need a higher level of care? If that doesn't happen, is it reasonable to try to coordinate something in the community that reduces risk by taking away some of her meds, controlling her meds more? They can't do mid-monitoring at Valley, but we can certainly reduce what she has access to that we know. And so that was all part of the discussion, and today.
So if we were to try to map your agenda, what questions do you most want to get feedback about? Is it the primary concerns that you've talked about, whether the patient has an OUD, if MAT is appropriate, is the question whether harm reduction is actually less harmful than contingencies where you hold MAT until she does certain things? Is that basically your questions, or are there other questions?
I think the last one for us right now, since, we basically held MAT. It felt weird for me to give her hydrocodone over the weekend and not just start, but that was the team's, and I agreed with it, but after sort of jumping full force into the whole harm reduction thing, it felt odd to me. And so, holding, I totally understand all the concerns, and, but I guess I'm just curious what other people think about that. You have somebody who's on high dose benzodiazepines, using other drugs, kind of resistant to change. She's come around. I think she will be monitored very closely, pill counts and short numbers of pills and weekly visits for a long time. And she did come and have an appointment with our psychologist already, so that was all good. She's been engaging in the care. I do keep saying thanks for glad you came back, because I never know if she's going to just be done with us. But I think that would be my biggest concern, but I don't know. I was not the last to see her, so what would you say?
Yeah, what do you do with taking just higher and higher doses of the opioids? It makes sense to me to switch her over, and that seems safer to me, but I guess what's everyone else's thoughts?
So maybe at this point we could ask the audience if there are any clarifying questions that they have about this case.
It's Dr. Carpenter. I just have one. What was was she in a state of withdrawal the first time you saw her, or even the second time? And what did we establish was her opiate usage leading up to this? Was it just the illicit buprenorphine use, or was there ever, recently, was there heroin? Was it high dose prescription use? What was that like?
It was high dose prescription use with buprenorphine when she ran out. So she would just go through her prescriptions, and then when she was out, she'd get some bup on the street, it sounded like, or other oxys, and then other benzos too. She had admitted to taking Ativan from somebody. And when I say streets, actually, she was very adamant that she wasn't buying it on the streets, that she just has friends who would offer it to her. So somehow that made that different in her mind. But and no heroin use, because and no injecting drugs at all, no meth. Yeah, opioid is her drug of choice for sure. But she likes her pot. That also doesn't count either.
I also have another question. Was there anything on the PDMP that surprised you?
No, she really had been following. I mean, she's been being seen by pain management most recently, and she was adhering to that. That was exactly what we knew of. I just think she was playing the really good game of getting that prescription, blowing through it, using what she could from other people, and then showing up for her appointments. And I think recently she scared herself with a period of blackout.
Was she adherent with her other medication, like her escitalopram and amitriptyline, that might better control her anxiety at least?
Yes, she's on amitriptyline. She's actually just started taking for migraines, but she thinks that that's helping quite a bit. And I don't know if she's on any.
I saw escitalopram on the case
Yep,
doc.
there you go. Yep. Mm-hmm, yep. So yeah, we would certainly want to talk about using those more. I can't remember the dose off the top of my head, but yeah. I have the hardest time of anything with patients, even patients not with addictions, but getting somebody off of benzodiazepine is really hard.
And Chris, she wasn't in withdrawal when we've been seeing her, right? That was Dr. Carpenter's. Yeah.
She had bupe in her system when I first met her. And I think then she had the high dose of hydrocodone when she came in the other day. So.
Yeah. So my thoughts were, and I was ambivalent about this too, but my thoughts were, I wanted to know more about her history. Did she have any evidence of sleep apnea? Were there other things that were going to increase her risk before we start, switching her over? I don't like to use this term, but I wanted to make sure that she was engaging and that we had her attention, particularly with all that she was using on the street. And so with her significant medical risks and what she was using, I was wanting to get a little more information and make sure she was following through. That wasn't necessarily best. I mean, the argument could be, well, should we have started her automatically, on some Suboxone, although she wasn't in withdrawal yet, we would have had to go through the same process. So on the one hand, my sense is kind of a typical patient, but on the other hand, a very complicated patient with lots of variables. So Dr. Carpenter, given, what's your threshold for starting somebody on an induction with severe cardiovascular history, all the things on the streets, the depressants that a person is using? What's your threshold of comfort where you say, I'm just not willing to do this at OBOT?
I'd just like to point out it's not too late for any of us to go into dermatology.
We're not smart enough to do that. Yeah,
I wasn't either. I stood in the wrong line. So with that, again, it's something too where if you would have asked me that a year ago, 2 years ago, currently right now there are two people I can think of. Both of them don't always come in with their oxygen, which makes me feel real weird, but they have really significant respiratory. So it's usually like COPD. One of them I think had partial lung removal due to infection. So definitely, one of them had sleep apnea, but hadn't been adherent with the mask. So in my mind, it's just, I like to just stop and think if this is somebody that we can get into such a habit of prescribing bupe for somebody that has a problem with opiates. I just like to stop and think what is the behavior I'm trying to change? Because both of these individuals were using IV heroin, and it was verified, based off of other treatment records and their toxicologies. And at that point, it was if I can use buprenorphine, and this is how I would even document it. If I can use buprenorphine to change their relationship with opiates, so I can use this partial agonist with hopefully a ceiling effect. If it can change the outcome of this use, it will be a good thing. There's a chance it could, worsen. And so it would need to be that there was a significant issue with opiate use. There's other people who have significant respiratory issues, and maybe they're not daily, users, or the amount, we've had people come in saying that I use 15 milligrams of oxycodone 3 times a week. start somebody on buprenorphine 8 milligrams, like it's just kind of, it's not a bad thing. It's just, you just got to ask yourself why. So it's the threshold is basically, if I know what it is, I am trying to change, is it worth it? But there are definitely people who, and it's another thing I like to remind myself is, especially like these individuals that like come in with polysubstances, sedatives, opiates, gabapentin on top of it all. I do want to kind of stop myself real quick because, it's appropriate. It's appropriate to be mindful and saying, am I going to hurt this patient by starting, buprenorphine? Or in fact, like they've lived to the age of 54, taking, ginormous amounts more than that. So I try and I don't follow, I try and remind myself of that too. So and that's why I'm so impressed actually with the decisions that you guys did make, both in continuing the rapport to kind of doing that aspect of harm reduction. Just because if we get into the habit of things are good or bad, again, these really difficult scenarios are more about calculated risks. And to what I'm so sorry I didn't get your name, but to what the first nurse practitioner was saying was that, if I'm ever going to do something that sounds like a really bad idea, but I think it is going to be helpful, what I document in my note is, this could potentially worsen addiction. It could cause respiratory depression, but they failed these treatments, and I think it's going to help, and I'm going to manage this risk with the dispense, the dose, and the duration. So 7-day scripts at a low moderate dose with pill counts. I mean, if you can justify it and monitor it, try it.
And I think in this case, that's the other issue. She hasn't really failed other treatments. And so that was the other sorts of thing that we were trying to do is, can we reduce her risk by getting her involved in other treatments? And I think Amy alluded to this, for anxiety, or meeting a behavioral health specialist and starting to taper down. Even though she'd refused, she was going to taper down clonazepam, and controlling actually what she had or what we were prescribing in terms of amounts, all those sorts of things line those up.
This is Lisa. I think to that point, Andy, when you're looking at somebody like this with layers and layers of complexity, she's obviously got a lot of reasons she's got anxiety, both maybe underlying and her substance use disorder and psychosocial, et cetera. In a situation like this where, you get the impression that she's got lots of control with her opioid use, and that really is kind of driving the bus. I wonder, sometimes it feels like you have to really try to target what is the core. It's hard to, everything's interrelated, but what is the core driver at this moment in time? And, from this patient's perspective, it sounds like she's very protective of her dosing, and doesn't want to change a lot of things. So I wonder, when I hear Dr. Carpenter talking about, and maybe this isn't quite how you're thinking of it, Dr. Carpenter, but I sort of hear you thinking about stratifying risk and figuring out what is the highest risk, and what is it that I can push on to reduce any one of these risk variables, to reduce the overall risk, hopefully without increasing the other risks. And I really like the questions that you asked about what do I most want for this patient. And I kind of got distracted trying to imagine what I think the Valley community team would say about that. So I'm going to say, and then I'm going to ask them to tell us, but I thought the two things they probably want the most are, number one, they want this patient to stay alive, and number two, they want this patient to come back. But I don't know that, and so I wonder, I mean, I think that's what I might be wanting if I was in their shoes. But then I think what you're saying is, think about what you most want for a patient, or what you think is in their best interest, and then where can you push on the risk variables. And in some situations, it means they got a whole bunch of other stuff going on that historically and traditionally we would have said, oh no, we're not starting buprenorphine in this mess. But now given what people understand about risk reduction and harm reduction, there's a very different way of thinking about that. So can I just ask the Valley team, what do you most want for this patient?
And Chris ran out.
I know, it's such a good question, she left.
Are you there? Can we hear you?
Yep.
Okay, so Chris might come back in about more of the medication piece of it. I think I actually want to say that I'm pretty proud of the team too. You know, and when she came in and she went through the assessment part of it, and she met with me and she met with our providers, and initially our providers thought, I think we want to hold off on doing the induction with this person right now because of, you know, of all of these complicating factors. I thought it was interesting that, you know, after meeting with me, speaking with the provider giving her that message that we don't have a green light just yet, but here's kind of the plan we're thinking about. By that afternoon, the patient was in our psychologist's office. And so I think that says something about, you know, maybe the patient's genuineness about it, but I also think it says something maybe about the team and how we went about delivering that. I think, you know, compassion goes a long way. I think the patient could have walked right out if we wouldn't have, if somehow we wouldn't have been able to deliver the message in a good way. So at least from a behavioral health point of view, we do think she needs to kind of get started on with therapy. She seems to have a lot of residual grief issues related to the death of her son. She's also quite numb about certain things, and you can kind of tell when you meet with her that she comes in and she just kind of throws the story out there, which is probably the story that she kind of talks about over and over and over again, that she just kind of gets caught up in. So I think that would be good for her to be able to work that out with somebody. And then also the quality of life things related to her health. That would definitely be something that I would think behavioral health would want to be involved in terms of our end of things, not just related to the addiction piece of it, but then just her overall health. If she's going to survive this addiction, for what? You know, and how we're going to help her be able to do that. So at least that's, and the star of the show just walked back in.
So, Lisa, you want to repeat the question to Chris?
Sorry. That's okay. This actually was, this was Dr. Carpenter's question, and I really liked it. Because he asked, you know, what would you most want for this patient? And I was sort of putting together that what I thought he was doing with that was, you know, trying to focus on what do you think is the most urgent thing, and where are there variables that you can reduce risk? You know, that's really what harm reduction is about. And that it really causes us to think now in different ways than we used to. We're not nearly as black and white about we will do this or we won't do that because the patient is doing this or doing that. But it's more about kind of globally assessing what is worse. And so I was trying to, as he was talking, I was trying to imagine what I thought you would say about what you thought the risk and what you most wanted for this patient. And I thought of two things. Number one, I thought you want the patient to stay alive. And number two, you want the patient to come back. But I didn't know if that was what you would really most want. And so we were curious about that. And then through that lens, where would that lead you to think about how to reduce harm in this case?
Mm-hmm. So yeah, I would agree. One, concerned about, I would want her to not overdose. And I guess that I would tag a question on that is like, at what point, back to that harm reduction. She's not injecting heroin yet, but I mean, we sort of would assume that at some point she's would get there if we just let her go down that path. So yeah, one, stay alive, two, come back, and then three, just because we're integrated care her, like I think we could do some good for her if that's what she would want in terms of managing her other chronic diseases, feeling better. I mean, she does have some chronic knee issues, chronic back issues that if she were able to focus on those things and not be so worried about getting her pills. I think she needs some knee replacements and to do some other things. And we have been able to hear that she has 9 grandchildren that are very important for her, and she's already articulated that she wants to be around to be those grandchildren. So I think we would use that quickly to like as the motivation for her. I think that is her motivation. She wants to be healthy and hang out with them and be with them long term. So have her come back and then improve that quality of life for her, which I think at this point is being able to be with her grandkids.
And don't forget about her skin rash, the dermatologic concern. No, I'm just kidding. Speaking with the hat of, I guess, a rural family physician on, or a rural primary care provider, I've actually seen that work. I've actually seen it where you can address an immediate concern in the primary care realm that is not related to some of the other areas that are more difficult to satisfy the patient's agenda, and have that be a sort of a reason, a motivator that they're coming back for the ongoing care. But keeping them alive in between obviously is existential, and having them come back. So here's my question, just thinking like a country doctor, I guess. You know, we actually handle complex cases more often than you'd think. I don't know that. I know we all say that our patients are sicker and more complex than everybody else's in the next rural town, but I think we see a lot of complexity commonly, and we have a lot of actually evidence-based risk calculators for pancreatitis, or for even, let's say, liver transplant candidates. And sometimes when we have a patient who is either going to die of their liver disease or they're going to get a liver transplant, and we're dealing with that as a rural primary care provider, we want to get them into the transplant candidate zone if we can, if that's part of their objective, is to have a liver transplant. So my question regarding harm reduction in the case of opioid use disorder or polysubstance use is there an app for that? Do you have a calculator? And if not, maybe some of our experts can help with that, because you know there are a lot of there are polyvariables here. But yeah, if you have a patient who's got congestive heart failure and COPD and diabetes, and they're on a certain opioid morphine equivalent load, and they've also got a certain amount of benzodiazepines on board, I can imagine that there is a standard of care, there is a body of experience, and maybe in a number of years, we'll be able to give them a CHAD score for MAT qualifications. And then we can know which of those things are the things that are most pushing them into the risk of death, and work on those variables first to get them into the zone where we know MAT is more appropriate or less risky or across the line, just like we do now, saying we literally say some people are not good candidates for liver transplant. Comments, response?
I think it's a really good observation, Dave. And I think we often think in behavioral health wistfully about what it's going to look like in 5 years or 10 years when we have better evidence-based mapping around some of these things and better acceptance. I would probably defer to Dr. Carpenter, but I think at this point what we've got in terms of evidence is really mostly expert opinion and professional consensus. There aren't necessarily good objective metrics or risk calculators for this that I think any of us are aware of. Dr. Carpenter?
No, so I am a huge fan of looking at forms and screens and scales and risk, because I just think it's fascinating when people try and do this, and I can appreciate now how hard it is to develop one and actually get it accepted. So no, in terms of like what is out there currently, really there are some general ones like, my gosh, I think one's called, but all of them are so long. It's really not possible to do them like on a frequent basis. But I really like looking at the questions. But the LOCUS, LOCUS, it's a level of care utilization assessment. That's not an S, it's an A. But again, like it went through different axes of what's going on for substance use, particularly the DAPPER-3, DAPPER-3. Again, they're very long and detailed, and part of what I would agree, there's certain things like opiate use disorder, you know, buprenorphine, that has a lot of evidence, but it's these kind of symphonies of people that show up that's kind of like, what do I do first? There's Dr. Steven Stahl made these great books to teach neuropsychopharmacology. And one of the things that I remember was this picture in his book that was basically like a hierarchy of like, when you see a patient, you treat this top to down. And it starts off with like basically sedative, opiate, stimulant, addiction and withdrawal, psychosis, bipolar, PTSD, depression, anxiety. And then like way at the bottom is like nicotine dependence and ADHD. And he says that the reason that you do that is really before you treat any of the, you know, lesser ones, the treatments are going to be dependent on what's going on up here. Meaning like, if you are psychotic, I'm not concerned if you can focus right now. I want you to not be psychotic. And also too, like, you know, if somebody does have depression and they have good reasons for it, you know, a wonderful medicine is going to be a drop in the bucket with like meth and heroin. So with that though, it kind of gives you a risk stratification. And I love saying like, another analogy I kind of have is that show like Love It or List It, meaning like two sides, each one lists kind of like their wish list. Ultimately, like you're the one that's going to kind of pick the direction and they can choose yay or nay. But I like saying like, you know what, there is a lot going on and we can come up with a plan to address all of it, but we've got to go in a sequence of events. Using the words like you are not a good candidate for benzodiazepine treatment, and not necessarily for this case, but in general. But we can tell people like you don't actually meet criteria for that. That's, you know, Risperdal for depression is not a great choice. You know, there is a lot we can borrow from other areas of medicine. But to start off with basically saying, listen, anxiety can be horrible and we need to address it. We need to, before we even talk about this, we need to see opiate use become stabilized and, you know, appropriate sedative use stabilized and go from there. So.
Dr. Carpenter, this is Kurt Snyder. Curious how often you would do take-home naloxone or some overdose education on the front end with a candidate like this?
Great question. We actually do it for anybody we prescribe buprenorphine for. We also, you know, provide with Narcan. Some of it is because of to meet certain requirements, depending on which program somebody's in. You know, you need to at least say that you offered it and then offer it once a year. But and honestly, when I was in private practice, it's not something I did very aggressively. They have done it very aggressively at Brightview, and I've seen it save people's lives. And even people that have been stable for a year transferring over here, I'm like, also, I'm sending in a prescription of Narcan. People, even in stable recovery, have a higher risk of overdose, and you can just hold on to it. And, you know, I've not seen harm come from that.
And Kurt, you'll be happy to know that Valley is on top of that.
I was also going to add.
I did Narcan with the prescription, just so you know.
I was going to add that we at NDSU just got a grant from the state. We're going to be implementing a big pharmacist education program so that pharmacists will be using the opioid risk tool and another tool that we've developed for accidental overdose risk. So pharmacists in the state are going to be screening patients for interventions, which would include Narcan education and prescription, referral to treatment, and additional educational interventions about their risks. So you can partner with your pharmacies in your communities to work that in more of your patients as well.
I would just add to this that not only are like our individual patients such at risk, but the people they run with. They are so exposed to others that overdose. I can't tell you how many of them report either that they've personally had a near miss themselves or that they've witnessed it. So it's incredible in terms of the overall amount of them that see it.
Kurt, this is Lisa. Two things. I think there was an excellent question, and part of what you're speaking to is really a public health strategy, because putting the rescue drug in the hands of people with the OUD, it helps get it out where it's going to be used regardless, is one thing, and that I think that's really true. The second thing is I was thinking about what you said and what Chris talked about earlier in trying to get this person to come and to stay, because her chances of staying alive are obviously much higher if she stays engaged with Valley. And I was thinking about things like offering what they offered to this patient came in with the agenda of getting benzodiazepines and opiates if possible, and somehow in the mix getting buprenorphine in there, but and they didn't leap to that right away, but they started wrapping a treatment plan with empathy around her. And one of the things that they did was to say, hey, here's naloxone, you could die, you should take this. And I think you did a bunch of other things that really were very holistic and compassionate that helped start engaging this patient who is very ambivalent about the path that you may want to be taking her down. And I think one of the things about the primary care setting that is really unique and valuable for the prescription of buprenorphine is that it's a venue in which you can offer up lots of things that they want, and so you create a holding environment where you can hold them and keep them coming back while you engage them and start to overcome some of that resistance. And Kurt, is there anything else you want to say about that? And before I let you talk, I'm going to interrupt and say that Dr. Carpenter just got called away abruptly, and he apologized for having to leave.
No, I think that, I brought it up because there is the stigma that is, out there around, if you give them Narcan, that just encourages them to, to go over the top. Well, they're over the top already. That doesn't change how they use that way anyway. And it does save lives. University of New Mexico does it with everybody. There's a lot of places where the research is showing that it saves lives. And so I just think that, especially with the difficulty around access, we get people coming through our doors on Friday afternoons and in the late times where we can't get them into our programs at that moment in time, and where it's just really I think it's a tool that's underutilized. I was really glad to hear that it was, and we've underutilized it at Heartview over the years until we really kind of realized we got to get that. That's a first line defense that we got to get in their hands, and it might not save theirs. It might be their son or daughter that it saves, especially with her circumstance of the blackouts. And as you guys talked about that, I wondered, she describing using opiates to the point of blackouts. I'm wondering if she had the history already of some overdose.
Yeah, she could have. I certainly think that she was describing potential overdoses, but I asked her if she'd ever had overdosed or had to use Narcan, and she had said no. So I just think she's been very lucky. The other thing I just want to say is we have another patient who he himself does not carry Narcan. He's overdosed, he doesn't even know, countless times. But he basically said he's like, I don't carry it, but anyone he's in contact with, all his family, his girlfriend, his friends, anyone he's hanging out with day to day has it. And they've just sort of assured, he's just been surrounded with, which I just thought was novel too. It's not just the patient, like even though they're not going to be the ones, like you mentioned, Kurt. So it's good to make sure you're informing the families that they need to do this. And like, oh yeah, they've all used it. They've all had to do it. It's just part of the day until we get it figured out.
Still alive.
So I was also hard to see our high school is, I was filling out paperwork this morning for my son, and our local high school had an Narcan poster and where it was being stored. So I was really thrilled to see that. I thought that was a win in Grand Forks anyway.
So in the last couple minutes here, I'd like to ask Valley, did we just add to your questions, or did you get some support and help in answering the questions that you brought with this really, really great case?
I'll speak for myself. No, I think this was, I mean, we always will have more questions, and, you know, hopefully this patient's going to be inducted this afternoon with Lisa, and we'll just see how it goes. But I think I feel heartened and just good that I think the way we're doing MAT here, I think we're doing it the quote, like a good way. We're going to wrap around her tight, watch her closely, check in with our experts to make sure we're doing it appropriately and evidence-based, and we'll, so no, I feel good. Would you guys agree? Everyone else left to see patients, so it's
So maybe we could ask you to give us an update on this case a little ways down the road and let us know what's happening with it.
Absolutely, be happy to.
So with that, I just want to remind everybody to fill out your post-test and your evaluation. Those evaluations are really helpful to us to make sure you signed in for your site coordinator to send that in, and we really appreciate you being here today. So thank you very much.
Thank you.
Bye.
Thanks.
Thank you.